Title of my lecture here would be Timing of Implant Placement Post-Extraction, and we will focus on the aesthetic zone. And I want to give you an update on tissue biology and the treatment options you have as a clinician. And I give you more an overview. And then in the afternoon, I'm going to talk about one of these options we use most often in the aesthetic zone. We call that early implant placement with contour augmentation, as a GBR, over-contouring the local anatomy. And then we talk about selection of biomaterials, selection of bone grafts, and growth factors. And you will be surprised then to see when I talk about growth factors, what kind of growth factors I mean. Okay, so this would be the plan. I hope you will not be disappointed. I prepared these two lectures very well. Actually, I'm in that field now for many years, more than almost 30 years. And it's very rewarding to have these kind of opportunities, because then you present the work of 25, 30 years, and this is actually quite nice. Okay. My background, I'm working since I graduated in dentistry in 1980 at the University of Bern. I had the chance to stay now the fourth time abroad at other universities to see outside of this environment. And this dental school is rather small compared to the big US dental schools, but it's one of the top 5 in Europe at least. And it has a very strong reputation in the field of implant dentistry, periodontology, and also in caries research. And this all goes back to late Professor André Schröder, one of the 2 main pioneers of modern implant dentistry, Pierre Bronnemark and André Schröder, because he started in 1970 to play around with actually monkeys and titanium implants and so on. Today, we are in a routine phase that we treat roughly 800 patients per year in this small town. When I compare to New York, for example, this is a city of 200,000 people, that's nothing. And we have a very good collaboration between these departments. And above all, I have had the true privilege to work with Professor Urs Belzer since the early 1990s, and I think he probably was most important for us to help us. Okay. If you would like to have a handout of my 2 presentations, I'm more than happy to share them with you. You send just an email to this email address. This is the CE department of the dental school in Bern. And then by Monday, they have the 2 PDFs, top quality. There you see all the references I might show it to you, and also the cases. And you see, as we have heard, Dental XP is an educational platform. As I will show you my background, I consider myself an educator, so sharing the knowledge is most important to have a progress in the field. My background, you see, as I said, I'm now roughly 30 years in that field. In 2000, I had the chance to take over the Department of Oral Surgery and Stomatology. And so I could build up a group, and today I think I can say it's a very strong and very large group of researchers. And our activities have been in all the years in the field of implant dentistry, in surface technology, bone augmentation procedures, selection of biomaterials, and long-term documentation. It's my strong wish. You see, I will retire in Bern in 3 years, that we're going to have by then all our techniques documented with at least 10-year follow-up studies, 10-year studies to show how predictable they work. And that is, of course, the job of universities. I'm a very active clinician. I'm very proud for that as well. We have too many professors who never treat patients. I treat about 150 patients per year, all implant patients, predominantly partial dentures, many of them in the aesthetic zone, but also posterior areas. And as I said, I'm an active educator with the goal to help colleagues to become good clinicians or to get better clinicians. And I think that's all about it, and I will come back to that in about 2 minutes. Here in the States, I'm always asked also to declare my conflict of interest. When you see that many studies I will present to you, then it's absolutely clear that You cannot do that without the support of either foundations or commercial companies. And you see all the companies we have had financial support in all the years, and the foundations. Important fact is that this is all based on contracts, and the contracts are done by the lawyers of the University of Bern. And with that, of course, we have clear rules that these studies will be conducted in a scientific way. There is no dependence, and that's important. I'm not in any of the, I'm not a consultant to anybody. I'm not in a board of a company. I don't receive money from companies because I want to keep independent and I want to stick to certain principles. Okay. Before we go into the first topic, I also want to share a few critical thoughts with you. We heard, you see, I consider, and this is based on more than 30 years of experience and witnessing these developments, I consider that the situation in implant dentistry is not a good one right now. Because from my point of view, we see too many products in the market without any scientific documentation. The cheaper, the better. That's one of the slogans, I guess. You see, we see, but also a lot of clinical procedures being pushed by colleagues without any scientific documentation, and that makes it very difficult for the colleagues. We have too much show business on these stages, too much, and we hear that about high rates of complication failures in scientific papers and in the media. And we all know there is a hype on peri-implantitis. I see personally an increase in serious, really serious aesthetic failures, and they are increasing. And the second one I see, and this is my main reason why I go to Harvard for 6 months, because I want to write there a book on this topic with Urs Belzer, because we have treated and documented about 80 cases like this in the past 15 years, and some of absolute disaster and catastrophe. And I would say 95% of these complications and failures, the main reason is the clinician, or has been the clinician. So there is a serious problem in terms of treatment quality. When I hear about peri-implantitis, I'm also convinced that most of these peri-implantitis cases are actually caused by the clinicians when they treat these patients wrong, and then 5-8 years later these implants turn into infections. So education is really most important in these days to improve the situation, and I think we are all sitting in the same boat. If we cannot fix that problem, we're going to see that in 5 to 10 years that discipline might go south, because then the regulators, the politicians will start to kick in and tell us that implant dentistry is actually not a serious business. So this is very critical. Now, when we talk about education, about colleagues, then I think I put together a slide here I used once about 10 years ago at a meeting in England. When you consider all the dentists we have on the globe, there is like a market of dentists, and of course we have, as with all other professions, we have a bell curve. And I took that from the internet this morning, and I thought this looks actually pretty good. And this was about teachers. And they called on the left side low performers, average performers, and high performers. And I think you can apply that to every profession. And now when I superimpose the next slide and take these performers off, then I used that in London, I think it was 10 years ago, and said in the middle is the vast majority of colleagues, and I called them at that time to be Dr. Joe average. And then on the right side, we have Dr. Henry specialist, and you see Henry, why I use that. And then on the right side, we have Dr. Jimmy malpractice. And I think when we talk about education, we have to do everything to help to shift this curve more to the right, and also not only to present techniques that can be mastered by Dr. Henry specialists and completely forget the Dr. Joe averages. The educators should really teach procedures that are working in the hands of the average colleagues, because that is just a reality. And then I think we're going to have a good performance and good treatment outcomes in dental offices. And if we cannot improve that situation, I see a very bad future for implant dentistry. So I think it's our obligation to really adapt and also to make sure that we don't have here show business on stage. Who is the best, who is the fastest, whatever. We have to stick to evidence-based dentistry to show what works in the hands. And that's why I love to hear about this community of dental XP. I mean, that's the same what ITI is doing. You see, ITI has about 15,000, 16,000 members around the globe, and that's also community, and they exchange ideas, and we try to help them to be better clinicians, and I think that's exactly the essence of this meeting here. Okay, now I will stop now to discuss this kind of business. Now we go into the topic. Give you a short introduction. And as I said, we are in a field, in a stage of routine application. And in routine application means that in my group, at the oral surgery in Bern, treats roughly 550 patients. And most of them are baby boomers. And most of them are partially edentulous. The number one indication in our group is the single tooth replacement. First molar and aesthetic zone, predominant, also first premolar in the maxilla. We have a very low success and survival, very high success and survival rates in our group, as documented by multiple publications. And that's only because we stick to specific protocols and we use them very consistently. We are not changing our protocols every 6 months. We try to modify them very carefully, but we are in a phase of fine-tuning of our techniques, and we're not having the big progress what we did in the 1980s and 1990s. We published 2 papers on our patient pool. That's interesting concerning age. The light blue bars is a patient pool 2002, 2004, and you see the predominant age category was between 50 and 60. And 6 years later, you see already the shift going to the right. So all of a sudden now 61 to 70 is the most frequent age category. And I analyzed a non-published the age distribution in 2014, and you see this trend continues to happen. So now in our group, the average patient is 57 years of age. And when you look at in this table, how the distribution is patients aged 80 plus, we are already at 5%. When you take 70 plus, it's 21%. 1 out of 5 is a senior patient, and this trend will continue to go more to the right and more to the right. What is the consequence? The consequence is that when you treat patients, you're going to see more often these kind of patients where you have patients with a medical and a dental compromise situation. These are not the young chickens you see, single tooth, traumatic tooth loss, and the rest is perfect. This is just not the reality in private office. The reality is that they are periodontally compromised, they have old fillings, whatever you see, and I think that is what we should really stick to. So this is one of the clinical realities, that we are dealing with compromised clinical situations. Now, implant placement post-extraction is a very frequent situation today. It dominates my clinical practice. When we go to the SAC classification of ITI, straightforward, advanced, complex, this is either advanced or complex. It's never straightforward. And of course, the problem is if you mess up in the aesthetic zone, then you have a serious problem for the patient, because then it looks ugly and this patient is not going to be your friend anymore. And that's not the best marketing for your office as well. So we have to make sure that we understand that timing is crucial in terms of when to place and when to restore an implant to get successful outcomes. So In Switzerland, I don't know. I always have an idea that in Europe and in the United States, the patients are a little bit different. I'm not so sure if this is really true. But when I go to congresses, I get the feeling. My patients, and I have treated several thousands, you see, they primarily ask for successful outcomes, high predictability, low complication rate. And I always call that these are the primary objectives of therapy. That's my ultimate goal to get. And today, actually, I communicate with my patients. The goal is that this should last for at least 30 years, because my oldest patients now are 30 plus years, and I have seen already about a dozen of them, you see. So that's absolutely possible. In 10 years, we will say 40 years is possible, but we have not yet documented these cases. But of course, there are also secondary objectives. Patients are afraid of surgery, so they want to have the least number of surgeries, they want to have the least morbidity, they want to have short healing periods, and also good cost effectiveness. In Switzerland, fee for service is 90% of the business. This is not healthcare systems or so. Only the trauma cases are covered by insurance. So we call them secondary objectives, and I think that's what we discussed with the Salama brothers and with Dave Garber and many others for all these years to make this treatment more patient-friendly or consumer-friendly, you could also say. And I think we have made great progress. But when we modify the techniques to improve these secondary objectives, we should never compromise on our primary objectives. That is a thin line to walk along. Okay, ITI has done these ITI treatment guides, and this is treatment guide number 3 devoted to this topic, and in that, Stephen Chen and myself, we have had this graph the first time, that there are 4 circles to influence treatment outcomes. The clinician or the clinical team, the patient with all the risk factors, the treatment approach, because you have several options and you have to choose your most appropriate treatment approach, and the biomaterials. And you see they have all a relation with each other. Today when I show this slide, then normally I show it like this, because based on all the years I have observing now, I get the feeling that 80% of a long-term success is in the hands of the clinician or the clinical team. That involves the surgeon, the prosthodontist, or if it's one person, the clinician, but also dental hygienist for long-term maintenance, and the technician, of course. So it's a whole team to take care of the patient, and I would say that's about 80% of the success story. And you see with the clinician, it's the education of the clinician, it's the skills, that's again the bell curve, and it's the experience. When colleagues are doing 10 implants a year, they should not do them in the aesthetic zone, because that will never work. And I think these are critical questions and difficult questions. When we talk about treatment approach, then of course you have a whole range of gray zones. On the 2 opposite sides, you have evidence-based approach and you have the cowboy techniques on the other side. And in between all the gray zones you can have, depending on what we are talking about. Okay, my strategies in our department that we try to stick to evidence-based approach. We are involved with ITI consensus conferences. There are always recommendations. And when you stick to these recommendations, you have a pretty good support for your decisions. And the second point, also important, we only utilize well-documented biomaterials concerning implant selection, bone fillers, barrier membranes, and so on and so on. And that served us very well. That's how we got these excellent long-term results. Okay, that's my second last. Before we go to the next topic is, what are the principles for implant surgery? I learned, and this is the discussion with Dave Garber in the mid-90s, that restoration-driven implant placement. This is a paper of Dave Garber and Urs Belzer, 95 or 96. First time they used that term. Restoration-driven implant placement with good primary stability, of course, most important. Second, and that is from the longevity of the implant probably the number one, that the implant must be completely embedded circumferentially in bone. Because when I see patients with problems, then they have a lack of bone, mostly on the facial aspect. Patients who are not treated according to the principles, they start without any buccal bone wall from beginning, and these top surfaces we have today get exposed into the sulcus, and then the biofilm starts to populate that surface, and it takes 5-8 years, and the patient has an infection. And then everybody is surprised. So this is most important point. And in the aesthetic zone, it's also important for soft tissue support. And the last point is also that we should have healthy and keratinized mucosa. That will not be the topic of my lecture, but so I will focus on the bone today, how to fix that. Okay, based on that, we have developed a recipe in the last 20 years, I would say. And these are 5 important points, and I will come back to that recipe during my two lectures from time to time, and then just remind you, and I will not discuss them right now, but we will start then with the second point very quickly. Okay, now when I say bone augmentation is important, then you might ask me, why is it important? When you pull a tooth in the aesthetic zone, you have different scenarios. You can have a patient with a thick facial wall, or a thin facial wall, or actually no facial wall because of infection. And the need for facial bone augmentation in aesthetic sites, this is mainly driven by one aspect, and this is called the biology. We learned a lot in the last 10 years about this biology, and that's what I would like to talk with you now. You see that we have to build up that bone when it's resorbed, to have this circumferential anchorage for osseointegration, but also to have it as a soft tissue support for nice-looking aesthetics. These are the 2 key parameters for long-term success in the aesthetic zone. Okay, so we start now with the tissue biology. And as I said, this is one of the 2 aspects when I said the clinician must have a good understanding of tissue biology. That's why we teach our postdoc students this tissue biology. And we have learned, and this goes back to the Scandinavian group in Sweden primarily and in Denmark. The group of Jan Linde taught us in the beginning how this works, and then this has triggered a lot of research in the past 10 years. They came up with the so-called theory of bundle bone resorption, and I want to discuss that now in detail. See. And these were the 2 landmark papers of Araujo and Jan Linde. That means these are premolar sites in beagle dogs, and you see that when you pull a tooth and then take histology after 8 weeks, you see not the same level of bone height, lingually and buccally, and the difference is about 2.5 millimeters. And then, of course, at that time, people were thinking, yeah, when we put an implant into such an extraction socket, this implant will stop this process, and the studies showed it does not. And today we know this is not stopped by the placement of an implant. What we did in our group, and this is now a paper published in Journal of Dental Research. The researchers here, they know how tough it is to get papers into that journal. It's the top #1 journal in terms of impact factor, with a rejection rate of 90%. So we try with our young colleagues to get into these journals, because at universities, they look into these numbers very carefully. And Dr. Chapuis, she's my best young female surgeon. I can only then discuss with our friends here to invite her once, because she's top talent. She's like what we have been 20 years ago. And what we did actually, we said these Araujo papers are done in premolars of beagle dogs. And we cannot translate from a beagle dog premolar to the aesthetic zone of a patient. That might be different. And that's why we said, of course, we cannot do histology, but we can take a cone beam. This is a non-invasive way to take a radiograph. And today the technology gives you the chance to do very small cone beams, 4 by 4 centimeters. And then, of course, the ethical committees then approved that you take 2 in the same patient. And we did that in 39 patients. And most important, we not only analyzed the mid-facial position of the socket, we also analyzed the position approximally, mesially and distally, because in Araujo it's always in the middle of the tooth. And from a clinical point of view, that's not actually the most relevant area to know what's going to happen. Okay, here you see with top technology, we teamed up with a computer specialist from a research institute in Bern. So you take a cone beam, and then that gives you then a surface mesh model, and then you can superimpose and use color distinction, whatever, and then you can show that in some patients you lose significant vertical bone between day 0 and day 8 weeks of healing. So these were the 2 time points, exactly 8 weeks. And we have seen immediately that there is a difference between patients, and we call this the thin wall phenotype patient who's losing a lot of bone, and the thick wall phenotype who's losing just a little bit at the rim of the facial wall, millimeter or so. And of course, you have to quantify this. First observation is that this vertical bone resorption only takes place in the middle of the socket, and minimal changes are observed mesially and distally to the socket. It has to be mentioned that these extractions were done flapless, no flap elevation, most important. And you see now here the thick phenotype with a thick facial wall, and you see the wall is intact at 8 weeks, a little bit of change here, whereas the thin phenotype, the thin wall is completely gone. And then, of course, you can also measure that, and this is now the vertical bone resorption with a regression analysis, and this is the percentage of vertical loss, and this is the thickness of the facial bone wall at extraction. And we saw very quickly that actually it seems that the 1 millimeter is like a threshold, because when you go beyond 1 millimeter thickness, then the resorption pattern is very low, and you see that the thick wall phenotypes had a median vertical bone loss of 1.1 millimeter, whereas the thin wall phenotypes had one of 7.5. Threefold what we have learned from the beagle dog studies of Araujo. Okay, so that was an important information, but it actually confirmed our clinical observation. And the conclusion is that this threshold of 1 millimeter facial wall thickness is a very important aspect when you analyze a patient before you go for your decision. What is the most appropriate treatment scenario? So important, of course, is now how often is that, you see? Cone beam for sure has given us a fantastic tool to measure that. And we did a study published in 2011 in Dr. Nevin's journal, where we analyzed the thickness of facial bone wall in the aesthetic zone between premolar to premolar. It was done on 125 cone beams. And you can see that actually the thickness of the facial wall in central incisors is rather thin. Thick facial wall, which is the green bar, is less than 5%, whereas for first premolars, it's almost 30%. So there are significant differences, at least in that patient pool material. So that means in the aesthetic zone, we are most often confronted with a thin wall phenotype. And this is not only in the Bernese group, this is also in the States, because this is a paper by the group of Lyndon Cooper. Same observation. Also in Brazil, you see that's Araujo's group again, where they measured that. And actually, all the studies show that the mean value of the facial wall thickness is between 0.6 and 0.8 millimeter. And this is mainly bundle bone and resorbs within 2 to 4 weeks post-extraction. This is an animal histology from a premolar, and you see, even if you have a thick facial wall, as you can see here, the rim or the top of this facial wall is composed of bundle bone. You see that beautifully. This is from Dr. Bossart. And this is actually what you see even in thick wall phenotypes, that you're going to lose on top 1 or 2 millimeters of bone when you pull that tooth. This is driven by biology, and we cannot influence this by any means. So this is I would say, this is the conclusion out of all these studies, and that's why facial contour augmentation is important if you want to optimize the aesthetic outcome in such conditions. Okay, now the next question is, you see, what about the soft tissues? We are all focused on bone so far, and there are almost no papers on soft tissue thickness. And since we had 39 cone beams, and in the same patient, actually, we took an impression after extraction, and then we took an impression digitally and with impression material after 2 weeks, 4 weeks, 6 weeks, and again 8 weeks, to see how quick the anatomy of the ridge is going to change. And this was a big surprise, because you see here also that you can superimpose these models, and you see here, obviously here is a lot of change, so there is a flattening in the middle of the socket. But the interesting observation was that there was no difference between thin bone phenotypes and thick bone phenotypes, because we have seen both. So now, when you have a clinical situation and there is no difference, and in one bone has resorbed and in the other one bone has not resorbed, then there is only one conclusion. In the case where the bone has resorbed, obviously the soft tissue has gotten thicker to compensate for that. And that's also certain risk. That means when you look at the case and it's just a little bit flattening, you get the impression that it's all bone. But that's only in some cases, in some patients, the case. So what we did, you see, we measured in these cone beams, and you see at extraction, the thickness on top of the bone was the same. And then when we had a thin bone phenotype, the thickness measured then was 5.3 millimeters, and here was still 0.7. So this is the change you have. And actually it's very easy to see. When there is a thin facial wall and this bone resorbs very quickly, we all know the GTR principle, you see. Then the soft tissue cells from the periosum have instant access to that socket, and then the soft tissue cells are much faster than the bone-forming cells, and therefore they form their soft tissue. And that is the explanation for this. So you get a spontaneous soft tissue thickening in thin bone phenotypes when you wait 8 weeks before you put the implant in. This is a big advantage in certain cases. And this is the comparison, just of course graphically depicted. When you have a thick wall phenotypes, then the tissue forming inside are mainly cells coming from the bony wall, so they will form bone. Whereas when there is no bone or the resorbed bone, then the soft tissue cells speed up and occupy that space, and that's why you get this thin alveolar crest when you have this kind of situation. So this is exactly, from a clinical point of view, the difference, although these two different situations from a clinical point of view, at 8 weeks, they look similar. There was no difference from a clinical point of view. Okay, so these are the numbers published also in Journal of Dental Research just 4 months ago. You see the thickness at 8 weeks, thick wall phenotypes you see from here going up to here. So the mean value roughly 5 millimeters, and based on the models we have taken, also the impressions, we could show that the changes take place mainly in the first 4 weeks of healing, also very rapidly. Okay, so this is the biologic background of this story. And now we go into the treatment options. And I want to show you how this has evolved, and I show here an ITI logo because this has been a predominant topic at 3 different ITI consensus conferences. We have them every 5 years, 2003, 2008, 2013. Next one will be scheduled 2018. And in the first one, you see, we try to define different time points, and they did that with type 1, type 2, type 3, and type 4. But then we figured out this is probably not so easy to communicate. We have to use descriptive terminology because immediate placement was already there. And then we decided that we have to do that in words. These are all the 3 supplements of CHOMI where their results have been published. And some of these papers are very highly cited, had a great impact. Okay, 2003, we made this definition with type 1 up to type 4, and then in 2008, we identified risk factors for mucosal recession because in 2003, we said immediate implants are well documented concerning implant survival, but there is a complete lack of aesthetic parameters at that time. And that was then defined in 2008, and here then the terminology immediate versus early versus late placement has been defined. We also made a decision that we are not going to use the term delayed placement because that's not very precise. When I pull a tooth, then tomorrow is delayed, and in 10 years is also delayed. So that does not really help the clinician to know when to go in and do that implant surgery. And in 2008, we also have seen that we had surprisingly high rates of mucosal recession for immediate implants. And 2013, then we have seen in several studies that when patients have been selected with strict criteria, immediate implant placement has improved significantly, and this rate of mucosal recession has dropped again. So the immediate implant placement has been analyzed in this paper with Stephen Chen and myself. That was a sabbatical in Melbourne in 2007. And the study showed that when you go in at day of extraction, then, and when you apply this technique without any selection of patients, then you run very quickly into major problems. And you see, I have observed in Bern several of these patients sent to us if we could fix the case with mucosal recession, with a mucosal surgery or so. And in most of these patients, I had to tell the patient, you see, there's only one option. We have to get them off and do the treatment again. And you can believe these patients were not very happy about this advice. And in one paper by Evans, you see, and Chen, they have analyzed this a patient pool from specialists in Melbourne that in about 40% they had a recession of 1 millimeter or more, and of course about 20% quite severe recessions between 1.5 and 3 millimeters. They identified in this group, you see that the thin tissue biotype was a risk factor, and also the facial malposition, that often implants end up in a wrong position, and then the result is a recession. So in that paper, we had about 7 different studies from all over the globe, all top groups, and they reported a frequency of mucosal recession, sometimes a little bit frightening. And I would say, when I summarize it, 20 to 30% have a risk of mucosal recession of more than 1 millimeter if applied without any inclusion criteria. If you just take every patient, you treat 10 and 3 of them will end up in a recession. We also don't have a lot of data concerning the long-term fate of facial bone wall thickness, because these are currently the papers we have available with cone beam, and you see these are all studies done without inclusion criteria. So the percentage of a lack of facial bone wall is quite frightening, between 25 and 55%. Of course, it could be that these implants still have a very thin layer of bone and it's not detectable on cone beams, but for sure not a 0.5 millimeter or 1 millimeter, 2 millimeter facial wall. This is a study by the group again of Linden Cooper, and this shows very nicely, small group, that in 7 immediate implants, you see, at 1 year with a cone beam, none of the 7 implants had a facial wall all the way up to the implant shoulder, and actually 4 out of 7 had one, and 3 had a complete lack of facial wall. So, I mean, this is a very serious group, top clinicians, and I think this is just a warning signal. So ITI picked it up in 2013 with a new systematic review. This was the group of experts. This is the review paper published then in Show Me 2014. And the result was then the recommended clinical procedures were then summarized, and ITI said, based on this data now, immediate implant placement is a complex procedure, can be used in well-selected cases with good outcomes, and they defined the conditions that should be satisfied, and it has intact socket wall and at least 1 millimeter in thickness. So the thick wall phenotype was then here put into this recommendation. Here's a case by Stephen Chen that documents nicely that you can have excellent short-term results because it's only 1 year follow-up on that case. You see a facial wall of good thickness, and they have done here immediate extraction, also flapless extraction, flapless implant placement, and immediate restoration. Correct positioning is imperative, we all know that. And you see here then an indexing, and then the grafting inside the socket wall with a low substitution filler. He used something to seal it off here, and then the patient has gotten this provisional same day. And you see the 1 year follow-up indicates a very nice treatment outcome. That's very attractive, no question. And I always say when we have a site where we can go for immediate placement, I would always really strongly advocate to do that flapless, because then it's for the patient the best benefit in terms of morbidity. But it includes a thick facial wall that should be present for that treatment approach. Okay, so again, when we go back to our scheme here, clinician, patient, treatment approach, and biomaterials, I could say yes, immediate implant placement is a complex procedure. You should be a master clinician with skills and experience to do that, and you need to select your cases in ideal situation, then you're going to be very successful. That's the message when you talk about this approach. Okay, early placement. This will be the topic this afternoon, then in full detail, published in 2008, then a paper of methodology with the rationale for it. And here you see, this is the middle version here. That means you wait 4 to 8 weeks to get the soft tissues to heal. That's all. Bundle bone resorbs. You get a spontaneous soft tissue thickening, and then you go in. And ITI recommendation was when there is no situation for immediate placement, then early placement should be favored. And this paper here in detail, these are the steps I will explain to you then in the afternoon in detail. Extraction is done flapless. You get an additional zone of keratinized mucosa. I'm not using a punch technique with a mucosal flap from a mucosal punch from the palate in routine cases. I just let Mother Nature do the job for me. And we get the spontaneous soft tissue thickening, and we get, of course, the bundle bone to resorb. So when you open up, as shown by this paper by Chapuis, you see, the changes are here in the middle, but there is no change here. So the width of the crest is more or less the same what you had when you did the extraction. And now what you need for a regenerative outcome is that you need an implant inside the bony housing, a terminology established more than 20 years ago by Sasha Jovanovic, you see. And this has absolute validity. So the exposed implant surface should be inside the alveolar housing, and then you get a two-wall defect. I will explain that this afternoon because this is the best a precondition for successful bone augmentation or regeneration of that bone. You need to give the right fillers to speed that up, and then you get an absolute predictable treatment outcome or regenerative outcome. So here one case that was in that paper. You see this is the extraction, you see a lack of keratinized mucosa. 8 weeks later, everything has healed, and now you have here 5 millimeters additional keratinization. And then flap elevation, correct 3D position of the implant, two-wall defect, the implant surface slightly inside the point of emergence, about 1 millimeter, 1.5. These are all agreements we have had late 1990s, I would say. And then the augmentation, we are preferring 2 fillers, a combination of autogenous bone chips and a low substitution filler, such as DBBM. We normally go for a collagen membrane to eliminate then a second surgery for the patient, and we go for primary wound closure. 8 weeks later, the reopening, provisionalization, soft tissue conditioning, and then final restoration. And you see here at 6 years, the same patient, and I will show you these data then in the afternoon. And here you see the same patient half a year ago, 9 years now. So that means we're gonna see this patient this year for 10-year follow-up. And you see radiographically excellent stability. Also soft tissues absolutely stable. Of course, you need a patient who cleans that mouth and who takes care of home care, and otherwise it will not be long-term. But that's also the job you have to provide, this maintenance care program with a dental hygienist. Okay. Do we have the third option? Early with some partial bone healing. Yes, we have that, but not very often. When you have a situation like this patient was referred to me post-extraction, and then I have seen on the periapical here a little radiolucency. We took a cone beam, and then actually we were a little bit surprised to see that this was a huge radiolucent defect from a periapical lesion. And then when we measured the height, then it was 16 millimeters. And I realized there's no way to do that at 4 to 8 weeks of healing, because the stability would be not easy to be achieved. But the beauty in that case was that the width of the crest has been 8.4 and 6.7 millimeters. So we told the patient, we just wait for you 4 months, do nothing, just let Mother Nature heal that bone, and then we put the implant in, and it worked beautifully. But that's one case a year. That's not very often. Now, the last option is late placement. Now, we all know when we treat patients, most of late placement is not intentional, because patients come 10 years after extraction because something else has been done, can be a bridge, and then in the pontic area you get the flattening, and then they lose the bridge, and then you start to think about implants, and then you have a flattened ridge. But of course, there are sometimes patients where you intentionally go for late placement. And this is when we have extended bone lesions and we cannot stabilize the implant, can be a cyst, or, and that's more often, adolescent patients being too young for implant placement. These are the trauma patients. A tooth has to be removed age 15, and have to wait at least 4 or 5 years before we put the implant in. Then, of course, you don't want to pull that tooth and do nothing, because otherwise the whole thing collapses. And this is this option here. And when we go to the ITI guidelines, then it says when we cannot do early or immediate placement, then we go for late, and then ridge preservation or augmentation procedures should be considered to avoid a complete collapse. And I think that's a very important recommendation. I have currently 2 patients in such a waiting position, young boys of 15 years. Now they are 18, 19, and soon we're going to check them again, and they still have a very nice alveolar ridge, a little flattening, but okay. And then we have to talk about ridge preservation technique by socket grafting, you see. And of course, you have different options. I've had a lot of publications. I also have to say, sometimes triggered by certain companies who try to sell their products. You see that every extraction gets a socket grafting. I think it's completely wrong. And don't get appetized too much in that direction. Because when we look at the literature again, you see, then we can see these are all the studies. It shows when you do socket grafting for ridge preservation that you can really slow down the amount of volume reduction, but you cannot stop the bundle bone resorption. It still collapses a little bit. These are two recent paper Araujo. You see, the difference is not that skyrocketing. Here, the volume reduction was 12%, an animal study by Araujo and Lindy. And it was also confirmed in this most recent systematic review from the States. And that means, you see, when you do socket grafting, you can slow down the collapse, but you will still see in the crestal area some resorption. And that means when you do late placement, you still have to do some simultaneous grafting to achieve a good aesthetic outcome. That's reality. But socket grafting eliminates the need for staged approach, ridge augmentation procedures, block grafts, whatever, and that is for sure an advantage for the patient. I show you two patients. You see, this is a cystic lesion. I treated about 6 years ago now, and you see, we pulled the tooth. The patient was symptomatic. Then the symptoms disappeared. The pressure disappeared through the socket. And then I opened up and took the cyst off. And then we did here you could say, a ridge preservation technique. It was not an augmentation. And you see, we used the typical fillers and membrane, and then 6 months later, we have been able to put an implant in, see in a nicely healed ridge, and this is then the restoration done by Dr. Wittneben. This is the 2-year follow-up, and I would say quite a decent result when you look at it. I have not seen the lady lately because Dr. Wittneben has given birth to 2 baby girls, and that's how then probably she did not document the case, but I will see that we can do that now. The other one is even more interesting, a case I did with Urs Belzer recently. See, patient came in age 15, an ankylosed tooth post-trauma, then 17 years of age, even more in an apical malposition, and you see a severe mucosal recession at this natural tooth. And then in 12 we started. Urs Belzer got retired in 2012 and ever since works 1 day per week in my department with the prosthetic group. And he's doing a lot of my patients now. You see, always on Tuesdays he works hard, harder than in Geneva. And you see here we cut down the Burden-Langer technique, cut down the crown and left the root in place and get then a spontaneous soft tissue healing. And then in March 13, we took the root off, removed all the remnants of this ankylosed root. And here now you see then 6 months later, we opened up the case and had a very nice healing, a little bit of flattening as expected. And I will show you this afternoon then the video clips of other patients to show how we do this contour augmentation, because here now you see implant is already placed, and these are the 2 fillers we are normally using. You see, locally harvested autogenous chips. I will show you this afternoon. This is full of growth factors, free of charge. And these are natural products because they do all the steps you need to form the bone. Because today I'm absolutely convinced if you add 1 growth factor to healing, that does not do anything compared to this, because this is not Mother Nature. And you see then a second filler will be on top of it, a low substitution filler. A membrane is nicely adapted, but I will explain that to you then in the afternoon. And then of course we normally go for a primary wound closure without tension. So when you look at this patient, you see this is then the patient in a year later with a provisional crown. We have been able to bring that back very nicely. The radiograph with the provisional crown shows a well-integrated bone-level implant, platform-switched concept. And this is the final restoration at the 2-year follow-up. I just realized that I did not receive from Urs Belzer the radiograph, but I will have to ask for that. But I would say that it's a very decent result compared to where we started from. And of course, important has been that we have been able to bring the bone back here to support our soft tissues. So I have 3.5 minutes left, and then I'm perfectly on time. I wanted to show you, and these are some conclusion slides now. See, you need to understand ridge alterations post-extraction, because this is much better understood today. The resorption of bundle bone is a biologic phenomenon. This is biology. This is not driven by a marketing expert of a company. And you cannot influence that. Not by surgical means, not by prosthetic means. It happens. So therefore, you must compensate this with contour augmentation. Not every case. When there is a thick facial wall, then you lose just a little bit. So that's probably not a problem. And this bone structure you have to rebuild is important for the aesthetic outcome of patients. When we talk about treatment options in post-extraction sites, then it's important to understand you have a variety of treatment options. You have 4 options actually. Immediate placement, early placement with 2 options, or late placement. As a clinician, you should go for the treatment approach where you can expect the best predictability for successful outcomes. The least risk for complications. That would be my pledge. And the treatment approach depends on anatomic risk factors. So you have to analyze the patient very carefully. When you go for immediate implant placement, you should be master clinician. Do that on a frequent basis with talent and good experience. And you have to select your patients very carefully. If you apply this technique without inclusion criteria, then you run the risk to have severe facial mucosal recession. Early placement, this type 2, is preferred by our group in most patients, not all. You see, it has rather short healing periods. You have to use contour augmentation. I will explain that this afternoon, and we go for primary wound closure to protect applied biomaterials. And then late placement is rarely used, and only in sites where you cannot go for immediate or early placement. So these are either extended bone lesions like cysts where you cannot stabilize an implant, or when you have these youngsters too young for implant placement when they have dental trauma situation. In such situations, we strongly advocate socket grafting for ridge preservation to reduce the amount of collapse in that field for the implant surgery to follow a couple of years later. So you see, you have all 3 options. All of them you can use, but not to the same extent from my point of view. As a master clinician, I don't know, might be 10%. I know many are doing 10% immediate placement. They do more often early placement with contour augmentation, and probably not very often late placement, because that's the least for the patient, because it has to wait a long period of time. But I think it's important that we have to stop to have this either or and this black and white. You have the whole range, and you can choose based on your talent and experience and based on the anatomy of a given situation. Okay, that will be the title of this afternoon, and then I go more into early placement, contour augmentation, selection of biomaterials. And with that, I thank you very much for your kind attention, and Henry, I hope you're satisfied.